Morning, everybody. My name is Jeff Chien. I'm the clinical instructor at Stanford University Hospital. It's my pleasure today to talk to you about myasthenia crisis. As a junior faculty member, as yet still no disclosures, I'll let you guys know when that changes. So this talk was actually inspired when I was a resident. I saw a case where a patient came in with a history of myasthenia, not looking very well. And I went through that mental gymnastics of, wait a minute, there were some considerations about this particular disease process that I read about in Rosen's that I really didn't remember. So myasthenia is a neuromuscular disease that, as a review, goes over the striated muscles. Of emergency medicine that we care about for board review, it's antibody-mediated and T-cell dependent. However, in emergency medicine, we're going to care most about the effectiveness of this disease process on the bulbar muscles and the respiratory muscles, namely exactly how much it's going to affect your ability to breathe and protect your airway. With the obligatory slide of pathophysiology, the autoantibodies non-competitively and permanently bind the postsynaptic receptors of an acetylcholine receptor. Remember, striated muscles, muscles that protect your airway, muscles that help you breathe. With those receptors completely and irreversibly knocked out, muscle depolarization downstream does not occur. The Teflon test, or the Autoantibodies challenge, is one of the board example answers of how to diagnose myasthenia. I have yet to see someone do one of these in the emergency department because I'm not doing it either. But we care about crisis, and crisis is defined to be weakness from myasthenia that requires intubation or delayed extubation, namely respiratory failure attributable to myasthenia. The precipitants for myasthenia gravis can range from infection to surgery to pregnancy, but one thing of special note is medication. Mestinon is one of the linchpins for medication of myasthenia, and actually when myasthenics they get sick, they have respiratory infection, anything of the sort, they're told early and often by their neurologists, well, take an extra dose, double it up. That medication can actually precipitate a crisis too. So if they're feeling unwell, that infectious etiology might be precipitating them, but the overdose of the Mestinon can be as well. So how do we work these guys up? Well, you have to have a high clinical suspicion. The general weakness can often mask that bulbar or respiratory distress. The infectious and metabolic workup as part of a lot of routine labs from triage can sometimes help with this, but again, the clinical suspicion is where we are going to find most of these. Pulmonary testing is the linchpin for what we care most about, which is whether the patient will protect their airway and whether they will breathe. Vital capacity reflects the volume of air coming in and out. The maximum inspiratory force, or the negative inspiratory force, tells you how much pressure that the pleura is using to pull air in. As a reminder, vital capacity is everything that doesn't count on a full breath that is not dead space. A wise teacher once taught me the poor man's vital capacity, if you don't have an ability to test for it in the ER, is to take a deep breath in and count out 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000. For your patient, every single number that they can get by works as an approximation of about 100 cc's of air. However, a negative inspiratory force, or a MIF, or NIF, will reflect the amount of force that your pleura is pulling on your lungs, how much force the air is going into the lungs with. It's measured in negative centimeters of water. And big numbers here, good. Low numbers, bad, because we're talking numbers, the amount of force with which that air is going into the lungs. I was taught early in residency, and I think everyone here was too, never intubate somebody based on a number, except in this case. If they're unable to mount a vital capacity of 20 cc's per kg, or if they can't get a MIF up to negative 30 centimeters of water, have a very, very low threshold to just take that airway for impending respiratory failure as part of their supportive care. When it comes to taking that airway in RSI, there's no difference in the induction agents, ketamine, propofol, etomidate, dealer's choice. But this is where I had that hang up from reading the textbook. Don't use succinylcholine in neuromuscular disease. Well, that was actually based on a case report in anesthesia. One patient, they were unable to achieve vocal cord relaxation with succinylcholine. So because of that, it's been propagated ever since. Actually, succinylcholine is safe for use in myasthenia gravis, especially in myasthenic crisis. It works. It's just described in case reports that you have to go up on the dose, actually, because remember, the autoantibody non-competitively and preferentially inhibits that receptor, so you just have to overwhelm it with more succinylcholine. The short half-life of succinylcholine usually means that it will not be a problem for delayed paralysis. Rocuronium is the preferred non-depolarizer. However, some caveats with it do exist, which is the fact that it will have a variable duration of onset given its mechanism of action. With the soon-to-come Sugamidex on the wide market, hopefully this will become a non-issue, but again, no studies on this as of yet. Definitive management of myasthenics, well, they've got to get to some sort of immunomodulation, IVIG, plasmapheresis, and so forth. But again, not anything necessarily I'd seen in the emergency department. Steroids we can start, 125 of solumedrol or 60 of prednisone can work for starts. But remember, things I want everyone to remember for myasthenic crisis, have a high clinical suspicion. General weakness can often hide that evidence of impending airway compromise. Pulmonary testing, vital capacity and NIFs will actually dictate whether or not you intubate a patient or not. Do your infectious and metabolic workups, start them on some sort of steroid, any sort of steroid. Consider IVIG or endorse them for IVIG as part of their admission. But double the sucks have to rock for their intubation if you've got to take their airways. A couple of references, and that's all I've got for you. Do you guys have any questions?